Kathleen Wright has been credentialed in critical care nursing for more than 20 years. She has received her cardiac surgery certification from the American Association of Critical Care Nurses. She has cared for cardiothoracic surgery patients during their post-operative stays in Bryn Mawr Hospital's intensive care for over 20 years, supporting unit-based protocols developed from evidence-based guidelines. She has taught in mainline health critical care courses, and she precepts and mentors newly hired critical care RNs in the ICU. Today, she will present some highlights from her talk on post-operative care of the off-pump CABG patient.
Thank you and welcome. Today we're going to review the post-operative care of the off-pump coronary artery bypass patient in a somewhat abbreviated manner. The objectives I hope to attain include sharing the background and the comorbidities of this patient population. I'll talk about the postoperative goals and especially the extubation data that we retrieve on a yearly basis. I'll talk about predictors and outcomes, postoperative pain of this patient population, and share some results and conclusions with you. In 2006, an estimated 7,235,000 inpatient cardiovascular operations and procedures were performed in the United States. That included angioplasties, diagnostic catheterizations, implantable defibrillators, and pacemaker insertions. And of that 7,235,000 number, 448,000 of these patients had bypass procedures. Now, some of the comorbid conditions that are associated with coronary artery disease include hypertension, a prior heart attack, decreased left ventricular function, chronic obstructive pulmonary disease, impaired renal function, and diabetes. The postoperative goals we're going to highlight today will include early extubation data and treatment of the postoperative pain of this patient population, keeping in mind that their hemodynamic stability, blood sugar control, early mobilization, medical therapy treatments, pain management, incisional support, and especially emotional support of the patient and family are also goals to be achieved. Our current extubation data for calendar years 03 to 09 in all cases of our patients, and that includes our valve patients. In calendar year 2009, many of our patients, about 75%, were extubated in the operating room, and a total of all case patients, again including valve patients, were extubated in less than 4 hours. And the significance of our valve patient population is that many of them are over 75 years of age, and therefore the comorbidity of this patient population come into play in the postoperative arena. Ben Zensen studied the predictors and the outcomes associated with early extubation in older adults undergoing coronary artery bypass surgery. They found that many older adults were easily extubated and had good outcomes, and that 50% of older adults were extubated in less than 6 hours. The outcomes were highly associated with comorbidities versus the physiologic changes that occurred with the specific surgery. Milgram looked at pain levels experienced with activities after cardiac surgery. They documented pain scores with activity. The activity included coughing, deep breathing, or the use of the incentive spirometer. They also looked at the patients when they were moving or turning in bed, getting out of bed or walking, and lastly, at rest or sitting in the chair. Milgram and Associates found when they measured the postoperative days 1 through 6, that the pain level was highest on the first postoperative day. They also found that coughing produced the highest level of pain, and the lowest pain level was achieved when the patient was at rest. They found that the pain was lower for the off-pump coronary artery bypass patients, and they saw a significant decrease in pain when the patient's chest tubes were removed. In summary, 88% of all of our CABG patients were extubated in the operating room, and only 5% remained on the ventilator for more than 24 hours in calendar year 2009. And in large part, this was due to the comorbid conditions of this patient population. The majority of our patients are stabilized sooner and therefore able to be mobilized 4 to 6 hours postoperatively. The patients have less reported side effects when surgery is done off pump as opposed to on bypass. We found that early intervention with regard to pain decreases the recovery time and the complications. We found that most patients can be transferred from the intensive care unit to the telemetry units the next day. We've also seen the off-pump CABG population progress our thinking so that we're more aggressive with all postoperative patients. We work as a team to collaborate on best practices, and we follow the evidence-based practice and the industry standards of care, and that includes the SCIP protocol, which stands for Surgical Care Improvement Project, for our best outcomes, and we incorporate these standards into our practice. Thank you for participating today. If you have any questions, feel free to contact me through my website.